We have this incredibly bloated financial sector. It's a phony crisis. They don't have to be cuts. We know how to get out of a Great Depression. You spend money. If we take a look at the typical worker, they're not doing fine.
Hi, I'm Dean Baker, your host for Mostly Economics. I'm here today with two of the younger generation of researchers at the Center for Economic and Policy Research, Brandon Novick and Emma Curchin, both of whom I've been fortunate to be able to work with some in the past couple of years. So I'm glad to have them on here. And today what we want to talk about is Medicare Advantage. I'm not sure how much people have heard of it. You'll hear a lot of it today. But it's a very big deal, and it's certainly a big deal in the context we're having this big debate over the budget and budget cuts. And if we're looking for a place to cut the budget, hard to think of a better place than Medicare Advantage. So let's start with that. And probably the best place to start in Medicare Advantage is just saying what it is, where it came from. So Brandon, Emma, do you want to kick off and tell us a little bit about the origins of Medicare Advantage?
Yeah, I can start, and then Brandon, interrupt me anytime. So if you haven't heard of MA or Medicare Advantage, you're either our age or you're not approaching the time where you get all the ads for getting on Medicare, which is age 65. You've probably seen an ad or two about it. What it is you've heard of Medicare likely. For anybody watching, it's the insurance we got on the closest thing to universal coverage, but it's for people just above 65. Medicare Advantage, even though it has the word Medicare, is not Medicare because it's run by private insurance conglomerates, big insurance companies. And sadly, 54% of people are actually on Medicare Advantage, even though it's, in our research, we find a lot of times a worse program for people. And we'll talk about that as the program goes on. But the origin of it is back in the, I think it was the 80s, the Tax Equity and Fiscal Responsibility Act. It introduced capitated payments into Medicare, led to the formation of Medicare Advantage. And we don't see like a huge jump in numbers until like 2005, closer to now, when the Medicare Modernization Act happened in 2003. But basically, back in the 80s, Medicare was allowed to contract with private health plans. The government said, you can make these partnerships. Let's make more private partnerships happen. And we'll pay you prospective monthly fixed per enrollee payments, and you'll get to provide the care you want to provide. So that's where it all started. And today, millions of people are on MA. More than half of people are on Medicare Advantage, which is not good news for the program. But Brandon, do you want to add anything?
No, that was a good coverage of where it came from. Like, private plans have been in Medicare since near its inception, but it really took off in the 80s and then in the 2003 legislation. But the big selling point of Medicare Advantage was that supposedly it would save money and be more efficient. And so the biggest thing to take away is that the program has never saved any money. Not only has it not saved any money, but it costs hundreds of billions of dollars. So just for 2025, MedPAC, which is the independent advisory body that advises Congress, estimated that the government or taxpayers will overpay these companies around $84 billion in just 1 year. And it's been like this for many years. So it's wasted hundreds of billions of dollars. So it's literally accomplished the opposite of its mission. Yet people still sign up to it for a variety of reasons that I assume we'll get into.
Yeah, okay. And, the point about MedPAC, this is important for people to understand. This is an independent agency. I don't know if we're going to have any of these anymore with Trump, where he's firing everyone, but ostensibly it's an independent, nonpartisan agency that reviews Medicare expenditures. That's what it exists for, to determine if they're being done in a proper way, if they can be done more efficiently. And they've consistently, I don't know how far back this goes. I've been following this for at least 2 decades, but it might go further back. They've consistently said that we're paying too much for Medicare Advantage. And the big trick, I'm sure there's more tricks, but the biggest trick that the companies have is that people are in effect risk rated, so that you have, I go in there and say I'm basically healthy, but they say, oh, you have a heart condition because you something X, Y, and Z. So they get someone say I have a heart condition, and then they get a larger payment. And that's a trick they've been doing, basically forever. Again, I'm sure they have others, but that's kind of the standard one. And as a result of that, we find, or I shouldn't say we, they, MedVac, finds that we consistently pay more on average for people who are in the Medicare Advantage program rather than the traditional Medicare program. You want to say a little bit about what it is, because, I see the commercials. I don't watch much TV, but if you put on CNN, you can't avoid them because they have an older audience. That's why you can't avoid them. But why it is that people are attracted to the Medicare Advantage plans? Why do they end up signing up for them?
Yeah, there's a variety of reasons. First of all, there's the fact that, CMS isn't putting out a bunch of advertisements advertising traditional Medicare. Well, Medicare Advantage companies, whether it be United Healthcare or Aetna, they're putting out ads. So they're literally doing the effort. But then there's the other issues, which are there are problems with traditional Medicare in that a lot of the upfront costs seem higher for traditional Medicare compared to Medicare Advantage. So I think the biggest thing is that, so if you're on Medicare Advantage, you have to pay your premium for Part B, but you have an out-of-pocket cap. So you're not going to spend over a certain amount of money. I think this year is over $9,000. You're not going to spend over that because the government requires this for these companies. There's no such requirement for traditional Medicare. So for Part A, for inpatient visits, there's a deductible for every stay you're in the hospital. It's around like $1,600. But after that deductible, after you meet that deductible, and if you're in the hospital for longer than 60 days, you can rack up more payments. And then for Part B, which is outpatient care, the government covers around 80% of the costs, but there's no out-of-pocket cap. So that 20% that the patient is paying can rack up. So for a lot of people, they say, "Oh, Medicare Advantage, there's a firm cap. There's often low or no additional premium. It just seems like the cheaper option." And then there's these advertisements which claim the immense benefit. They show happy families playing in a field. So it's a lot of emotional stuff and cost just up front.
And then the other big thing is that MA plans offer dental and vision oftentimes, which for most people is really, really important to get your teeth cleaned, to get eyeglasses. And a big weakness of traditional Medicare is they don't offer those right now. And so a lot of advocates are pushing to have that be included in traditional Medicare. But that gets people signed up. They'll even offer like food vouchers, extra cash cards. And this might sound like, okay, why would I choose traditional Medicare? But the trick is when people go and need actual complicated surgeries, actual more hospital stays, just more expensive care, more complicated care. That's when we hit the big problem with Medicare Advantage, which is that they require pre-authorization of those services, and they have some really narrow networks where they'll really, maybe in each county, I think the research says that maybe 50% of different hospitals and primary care offices are even part of a network. So you can't just show up and get care where you need it. And people in traditional Medicare can go really anywhere Medicare is accepted. So pre-authorizations, I can go into basically, you go to your doctor, you go to the hospital when you have a heart pain. They have to check with the insurance company that owns your MA plan whether you can even get that care. So most times when we go to the hospital, it's urgent. You need that care right away. But some people get there and they're on their MA plan. They think they like it. They show up and their provider says, actually, we have to wait till we talk to your insurance company to see whether we can do this. And then oftentimes they'll deny the care if it's too expensive. If people go back and they appeal, they'll oftentimes get it covered because a lot of these are mistakes and they're actually illegal, like improper denials. But most people don't make that effort because it's stressful and it's hard.
Well, actually, let me go back because I want to add a little more about the history here, because there's an interesting point that in Medicare, both programs, Medicare's formed in '65, and needless to say, the world, in particular healthcare, is very different in '65, and that explains, many of the issues that we see in Medicare today, and reasons why Medicare Advantage might seem better to a lot of people. So, in 65, it didn't cover dental care. Why didn't they cover it? It didn't seem like a big deal. Dentists pulled teeth, filled them. There wasn't a lot for dentists to do. So, you'd like for the government to pay for your dental care. It wasn't a big deal. Vision, these other hearing, these were not big things and they weren't covered. The point Brandon made about an out-of-pocket cap, healthcare expenses, covering 80% of your healthcare expenses is pretty good. But today that's not. I mean, if you have a serious illness, you're in the hospital, you could easily have a bill of 100, 200,000, and 20% of that's a lot of money. So people who might worry or might actually have serious healthcare conditions, if they're middle-class people, they have some money, they buy supplemental insurance. So in addition to your Medicare, you have to get supplemental insurance because you can't take the chance you're going to get stuck with a $40,000 medical bill. Now, it'd be the easiest thing in the world to Congress to address these things. It doesn't cost much. It's been a while since I looked at it. I did some scoring on it a few years back. If you put in the cap that we have for Medicare Advantage, $8,000 out of pocket, if you did that for the traditional program, it won't cost that much because thankfully most people don't have really large bills, but some people do, and you need to protect against the risk. Congress won't do that because they want to push people into Medicare Advantage. Same thing with the vision, covering hearing, dental. Again, Congress wants to push people into Medicare Advantage because they're lobbying people in Congress. The other big thing here, of course, is prescription drugs. Again, going back to 1965, drugs didn't cost anything. So it'd be like, oh, should Medicare cover your aspirin? You go, well, it'd be nice, but, most people, again, poor people, everything's expensive, but, middle-class person, they can pay for their own aspirin. It was the same way with drugs. We didn't spend anything on drugs in 1965. Currently, we're spending close to $700 billion a year. It's a really, really big deal. So we did eventually get drugs covered under Medicare, but again, they did it in really the most sleazy and inefficient way. Where was Doge when we needed them? They set up a separate program. And I remember once being on a panel with a very conservative guy from the Heritage Foundation. He goes, where do you have standalone drug programs in the private sector? So rather than just incorporating drug coverage in the traditional Medicare program, they said, no, we're going to have a standalone Part D. You have to get a separate insurance. Medicare covers most of it. Again, it's complicated, but it makes it much more complicated. Instead, you can get Medicare Advantage, and it's all rolled in. So this is all about pushing more people into the Medicare Advantage plans where the private insurance companies can profit from it. So that's my diatribe. I'm sorry. Let's go on. You're about to say more about where we stand now.
But I just wanted to hop in quickly on the when you brought the point of it costing a lot less. There was a recent we got access to a recent Brown University estimate for the cost of a $1,000 out-of-pocket cap, which for 2025 would have been around $44 billion. It sounds like a lot, but if you compare that to the fact that there's an estimated $84 billion overpayments to Medicare Advantage in the same year, you could see that we could close the big cost gap for patients at a fraction of the price of overpayments, which is basically just staffed by insurance companies. Another big thing to point out also is you're talking about the prescription drug coverage. I think it's also very telling that when the Inflation Reduction Act had that $2,000 out-of-pocket cap, a lot of MA companies got really mad and said, oh, we're going to have to reduce our plans or our benefits because it's going to cost us money. Because at the end of the day, they don't want to provide coverage. They want to save as much money as possible by spending as little as possible.
Yeah, someone, sorry to keep jumping in here, but I just love the analogy, and I wish I knew who to attribute it to because it's not mine. But they compared the incentives of the insurance companies, certainly Medicare Advantage, but insurance more generally, with the incentives of a normal retailer. So you think of Amazon, I can hate them whatever you want, but they work very hard to try and make it as easy as possible to buy things. Click the button, you get it. Click the button, you get something else. Medicare Advantage, as with any insurance company, they want to make it as difficult as possible. They don't want you to get the services because they make money by you not getting the services, and they're good at doing that. So anyhow, I'll shut up there. You were going to go on, Emma.
Oh no, that's really useful. They don't want you to use your healthcare, which I think says something about whether you should choose that plan. But I was just going to share that we think of pre-authorization right now as a really terrible, pain-inflicting process that's part of Medicare Advantage. But CMMI, which is like the innovation part of CMS, they just announced that they're starting a pilot model to put pre-authorization as a part of traditional Medicare, which is terrible, terrible news for traditional Medicare, the program that we want to keep. And I think this is something we're heading towards likely more in the next few years, is more efforts to make traditional Medicare more like Medicare Advantage. Not to say that Democrats in the past 4 years were very good curbing MA. They didn't make as many efforts as they could to put up these safeguards we need and regulate these companies. But it could get worse over the next 4 years too.
And it's not just that they're trying to introduce prior authorizations. They specifically say we want the contract with companies to do this that know how to use AI. Now, theoretically, in an ideal world, AI could be great, but we know that AI often can't do basic math. The administration used AI to make the Maha report, which made up sources or got things completely wrong. So there's no evidence that this would be reliable, yet they're saying we're going to entrust whether you get your care based on artificial intelligence, which we think is amazing, without any evidence.
Yeah, I'll just throw in something else here, just, again, kind of a common sense thing. People who need healthcare are sick. You have a health condition. And again, with Medicare, it's mostly older people. We also have people on disability. But again, they have issues, obviously, or they wouldn't be on disability. So what you're doing is you're making these people who are least able in important ways to deal with bureaucracy jump through all these hoops. So it's particularly cruel. Again, many of them will have, maybe a spouse, maybe a kid, maybe someone else who could walk them through the process. But if nothing else, that's certainly an inconvenience for the other person. But many don't. You have many older people that live by themselves and they have to really struggle. And in many cases, that's going to mean they don't get the care they need and they are entitled to, but they can't jump through the hoops. And again, it's one of these things that I just find incredible. We're seeing this more general, like people being thrown off Medicaid with work requirements. It's not because they're not working. It's because they don't fill out the right forms. So when it comes to people getting benefits that they're entitled to, we see this, we're just fine with creating more red tape, more bureaucracy, make them jump through hoops. But then when you talk about a company required to comply with workplace safety standards, environmental regulations, that's bureaucracy. They couldn't possibly deal with it, even though they've got teams of lawyers. They couldn't possibly deal with it. It's really kind of incredible that you get people saying both things. The companies that hire lawyers can't deal with bureaucracy, but you have an older person who has difficulty reading and they have to jump through all these hoops to get the care they need.
Yeah, I think it's a full-time job to fight for care if you get it denied. Like, I think that's hours on the phone with this company. And I've talked to people before. I met somebody who was the daughter of a man who died because he didn't get his care covered and didn't get his rehab care covered. And it was too late. And I think that's like many, many people whose stories we might not hear all the time, but those are the people that need to be on TV, is telling you, like, I wanted this for my parent, I wanted this for myself, this care, and this company decided it was too much money.
I'm curious, and you're probably more on top of this than I am. Have there been any champions of programs to, in effect, revitalize the traditional Medicare? Obviously we have people like Bernie Sanders who've been pushing for Medicare for all, which, to my view, would be great. But, within the existing structure, have there been champions of specific legislation? Again, I'm just not on top of it. Is there someone who's been pushing that in Congress? Obviously, it's not about to pass in this Congress, but, maybe in somewhere in the not too distant future, we might see reform Medicare that would be able to, one, service people, and two, win back, hate to use the term, but market share at the expense of Medicare Advantage.
Yeah, there hasn't been a super strong push on improving like traditional Medicare. It's more on just fighting back against the abuses in Medicare Advantage. A lot of the offices, not only on the defensive, but there's many that I've spoken to, which are also politically very cautious because they're susceptible to the talking point that, because the majority of people are on this thing now, we don't want to, even if they're Democrats, we don't want to go after it too hard because people like it, supposedly, and therefore we don't want to seem like we're against the program. And there's people who definitely members of Congress, especially on the more progressive side, that point out these things about being totally against Medicare Advantage, but they don't really have the political capital or desire right now to severely push for legislation because just feasibility is not there.
Yeah, no, that's understandable. And, thinking back to when the Affordable Care Act was being debated, and even going further back to Clinton's healthcare reform, you had the issue that most people, if you asked them, they said they liked their insurance company. I'm not sure if people would still say that because you had that story. I mean, I'm not going to defend the killing, but, the CEO of United Healthcare, of course, being, murdered, it was deliberate planned murder. And the guy's got a lot of sympathy. I mean, it's, which just speaks to, a lot of people being very upset at their insurer. And I don't know how widespread that is, but clearly a lot of people had sympathy for the guy. But in any case, polling does show most people in the past, again, I haven't seen recent polling, like their insurer. And there is a simple logic to that, thankfully, most people are reasonably healthy. So if you're healthy, you don't have a reason not to dislike your insurer because you don't have much to deal with them. It's when people have serious illnesses or a family member with serious illnesses that you have to deal with your insurer. And again, just the straight out logic, you don't have to say they're bad people, but just, they don't make more money by giving people health care. They make more money by keeping people from getting health care. It's about as simple as that. And that is a really big problem. But again, thankfully, most people are reasonably healthy. And that means they don't typically have to run to their insurer to have all sorts of, bills paid.
That actually points to one big problem which exists there where you have the situation where if you're healthy, you might like your MA plan because you don't need to use it. The problem is, though, is that when you do and you want the highest quality care, so there's really mixed evidence on studies that aren't very high quality saying what improves outcomes, traditional Medicare, Medicare Advantage. But among the things that we do know is that, and it makes sense with how the payment models work, is that Medicare Advantage companies are less likely to send patients who need a really expensive care to the best quality facilities because they cost more. But so if you're in a Medicare Advantage plan, now you get sick and you're like, I want to go on to traditional Medicare. Well, you're going to face a really high cost burden. And people traditionally on traditional Medicare, they might be like, okay, I'm going to pay a lot of money. So they're going to get what's called a Medigap plan or a supplement plan. And those can cost, I think on average, like $150 a month, but it depends on the type of plan. But the thing is, though, except for a handful of states, if you switch over from Medicare Advantage to traditional Medicare, you're not guaranteed to be accepted by a Medigap plan. So that means you're not going to get that, financial protection they provide, and you're going to have to pay insane amounts of money if you get that life-saving care. So that's a big caveat to people being really healthy and being like, I don't need to worry about going to traditional Medicare now because I don't need care. Well, when you do, you might not be covered.
That's actually a tremendous important point that, it'd be hard to exaggerate that with normal healthcare insurance, and this is the Affordable Care Act. This didn't used to be the case. You're younger. I don't know if you know the ancient history here, but it didn't used to be the case that insurers had to provide you coverage. And the Affordable Care Act changed that. They're not allowed to exclude people or discriminate based on your health condition. So it could charge a rate for people who are, man who's 45 or whatever, and everyone, doesn't matter if you had a heart condition or cancer or whatever, it's the same rate. If you go back before the Affordable Care Act was passed, if you had a heart condition, you're 45, whatever age, they're going to charge you up the wazoo because they could do that. Again, they don't want to bring on, they don't want a customer who's going to cost them huge amounts in bills. So they could turn you down altogether. That was legal. Or if they were going to give you a plan, they might charge you $50,000, $60,000 a year. And people in that situation, Affordable Care Act changed that, but they did not apply to Medigap plans. So they're totally within their rights. Again, I guess there's some states that now prohibit this, but they're totally within their rights to say, we're not going to cover you, or if we do cover you, we're going to charge you some crazy premium. And, that means, if you have a serious health issue, again, we care about insurance for when we have a serious health issue. And what that means is if you actually do have a serious health issue, it might not be there for you.
And this isn't MA specific, but in the latest bill that passed today in the Senate, one thing that I wrote about and released a piece about today was about this subsidy program called Extra Help, which a lot of people on Medicare use. It's basically using a Medicaid program. So you're low income and you're on Medicare, and this program you can qualify for if you're qualifying for Medicaid, and it helps you pay for your premiums, deductibles, copays. And as all these people get cut from the rolls of Medicaid, they're going to get off of this program, which helps millions of people. I think it's 14 million people pay for their prescriptions. And so that's another hard path ahead that we need to figure out to help people get their prescriptions paid for, which can often, as they're saying, be thousands and thousands and thousands of dollars a year.
That's really important about Medicaid, that, we traditionally think of Medicaid as a program for lower income people and now more moderate income people. We've moved up the income ladder a lot with expansion of the coverage, which might be a good thing. But in any case, we still think of it as a more low moderate income program for low moderate income people. But you have, and maybe one of you has the number, you have a very large number of Medicare beneficiaries who are also on Medicaid. And certainly this is true of a lot of people in nursing homes. And the story here is that Medicaid, has income and asset qualifications. And what very often you'll have is someone who might be totally very middle income during their working life and even their retirement years, but then they have a serious illness, they have to go into a nursing home, which is not covered under Medicare. And suddenly they spend down their assets. They might have had a house that they have to sell or mortgage off. And then they're covered by Medicaid. So we have a large number of, again, people through their whole working lives might have been very middle class, but they end up being covered by Medicaid in their older years. Okay, so let's transition a bit. We're in the situation now. We have, as we're discussing this, the big, beautiful bill just passed the Senate, and obviously we don't know exactly what its fate will be in the House, and presumably there'll be some changes, if it does end up on Trump's desk. So what are the immediate issues that we see in that bill for Medicare or the people who are on Medicare? Because again, we do have the dual eligibles who are on both Medicare and Medicaid. Do either of you want to say a bit about what that looks like?
Yeah, there's a lot of ways that the Medicaid cuts in particular can hurt people who are on Medicare. I don't have the number exactly, but there's millions of people who are above 65, are on Medicare, or use the Medicare program and make low enough income to qualify for Medicaid and have a bunch of programs that they can access because of that. Without the Medicaid help, as Brandon mentioned earlier in the episode, there's a lot of parts of healthcare, their healthcare experience, that are now unaffordable. One of them was the subsidy program I mentioned earlier called Part D Extra Help, which is aimed at helping people pay for their prescription drugs, their copays, their premiums. And that's going to likely go away. People are going to disenroll from Medicaid with the cuts and lose access to that program. So we need to remember there's many low-income people across the country right now who are urgently thinking about, how will I pay for the care I need? If I can't pay, I can't go get my prescription and I can't use it, and then I might die. There's a new study we referenced in this article I put out predicting 18,000 people will die as a result of this specific program being lost.
And the impact will be more than just people on these various programs. So a lot of states, they do what are called provider taxes. And these taxes basically allow the states to reimburse providers, hospitals more for services for their Medicaid beneficiaries, because Medicaid actually pays providers less for the same services as private insurance and Medicare. And a lot of hospitals and providers rely on these increased payments. And what this bill does is it limits and restricts these provider taxes so that over time they're not going to be able to get the higher payments they need, and they might have to reduce services or shut down. And that doesn't just affect people on Medicaid or Medicare, that affects everybody who needs those providers. So that's a massive problem for everyone who relies on these providers, and it furthers an additional problem we already have, which is too much concentration, where we have one hospital in a large area. And if that closes down, well, then the next available place to get care is miles and miles away. And now people have to travel a long time to get the care they need. And if it's an emergency, they might very well die.
Yeah, that's an incredibly important point that I think is often overlooked, that we're already seeing this, so this isn't pulling it out of space. We're already seeing a lot of closures of hospitals, and as you say, both leads to concentration, so that means in many cases market or they jack up the prices, in other words. But the other thing is that people literally don't have access to care. It could be many miles away, and particularly in rural areas that they might have to travel very far. So you have a lot of hospitals already on the edge, and when you cut back payments, which is definitely a part of this bill, clearly that's going to accelerate. We'll see more hospitals that go under, more providers, because we'll see nursing homes, other providers also go out. That is going to be a really big deal, really big consequence of this bill. So yeah, that will affect people. Medicare will affect everyone, basically. So
you're muted, Emma.
So I was going to go back. I'd raised the point because again, this is perhaps ancient history, but the idea of health maintenance organizations, and this dates back to the Kaiser, I forget what it was called originally, Kaiser not Foundation, maybe it was Foundation. Anyhow, it was started by the Kaiser Aluminum Company for their workers, and it was, the idea was that they would provide care for them, and the logic was that because you had the same group of people under your care, you did have an incentive to make sure they were in good health. So, and, by all accounts, Kaiser did do this. As I'm thinking back to the 30s and 40s, that they did actually have, and that continues. I don't mean to say it was just the 30s and 40s, but that's what it's dated from. So they did have an incentive to try to ensure that people were healthy, and that's what you'd like. At least I would like. You want to make sure that people stay in good health, and if that could be profitable in the sense that if they're in good health, they don't need expensive surgeries, expensive hospital stays. And that was kind of the logic, the promise of health maintenance organizations, which really started to take off in the 80s and 90s. And to some extent, that's the sort of thing that Medicare Advantage appeals to when they're trying to sell themselves, that, we're going to, we're provide, not just the normal medical services. We deal with vision, we deal with dental care. They don't live up to that, though. I think that's fair to say. I don't know. You guys want to throw something in on that?
Speaking of dental care, I was at a conference recently, and there was a researcher, and she was a dentist, and she shared that something like 90% of Medicare Advantage plans that have dental offerings, 90% of those dental plans are really low quality, and people don't actually get good dental care. So, MA plans are marketing like you should choose their plan just because it has dental offerings, but people get in them and they have terrible quality and they can't get a lot of what they need. And I think that's not getting out there enough too.
I also want to add that this whole debate kind of it completely misses the mark on some key issues that we have. So big things that people say in support of Medicare Advantage are, A, it saves money. We've already said it doesn't save any money. It's cost loads and billions of dollars of money, so that's just a lie. But the second thing is that the way it incentivizes, the payment structure incentivizes care, ideally, is that you give an insurance company a lump sum of money, which is called a capitated payment, and you say, okay, this payment based on the location of the patient and their risk, or how sick they are, and you take as good care of the patient as possible. And if you do that really well, you'll have some money left over, and you keep that as profit. And so in this world, it says this system would incentivize these companies to keep people healthy. Now, that's not actually what happens. We see companies instead trying to game the system by increasing the amount of money they get by pretending their patients are sicker than they are, or choosing people who are also healthier. But the general idea also misses the mark. Is the reason why Americans are sick? You have to ask, why is that? Is it because we pay fee-for-service in traditional Medicare? Is it only old people that are getting unhealthy, or is it also younger people who are on Medicare? Is it because of lack of access to care overall, or poor diet, or our sedentary lifestyles? There's a lot of big questions we have, and this idea that just paying insurance companies in a certain way is going to address that entirely misses the larger conversation we need to have.
That's a very good point. And, getting back to the issue of how you pay insurance companies, say get a kick out of it, it's probably the wrong expression, but there's a logic, it's the accepted wisdom among people on the right. Government can't do anything. They're a bunch of buffoons, whereas, the private sector, they're all really sharp, brilliant people. You go, okay, fine, let's assume that's right. So let's say that we have the government buffoons handing out money to insurance companies, the sharp, brilliant people. Well, what are they going to do? They're going to rip the government off, right? And that is what they do. And it's not because the government people are buffoons. It's because they're handcuffed. That Congress won't let them actually crack down, because you do have people, obviously, in the regulatory agencies who know about these abuses and they talk about them, but they don't have the power to crack down on them. But again, it's just kind of common sense. We'll take you at your word. Government buffoon, geniuses, brilliant people in the private sector. What happens when government puts out money in the private sector? They get ripped off. That would just be kind of common sense, you would think. But somehow they don't go.
Yeah, and
right.
I think they're sitting there. Everyone in Congress right now who's not talking about MA will regret that. I think they look silly if they don't speak out against this program, which is fully taking advantage of our taxpayer money and could be, like you said earlier, the exact fraud that they target. That the DOJ is cutting, the DOJ program is cutting things we need. They could be targeting the fraud that's in Medicare Advantage, but instead
they did talk about it
targeting
for like
good
5
programs
seconds
and making cuts right now that'll cut 11.3 million people from Medicaid.
Sorry to cut you off. I
That's
didn't,
okay.
but they did talk. Notice they did talk about it for like a week, and they were like, "Oh, I think it was Bill Cassidy. He brought up the his Upcode Act, the idea of restricting, upcoding, which is the practice of pretending patients are sicker than they are." And what happened? Right, media coverage was saying that they're floating Medicare cuts, as if they were going to cut benefits to Medicare patients and not overpayments to large insurance companies. And then you had, the industry, the insurance industry, spend a lot of money on lobbying and advertisements, rushing in to protect their beloved program. And then what do we see? The big, beautiful bill doesn't include cuts to overpayments, which are just blatant, waste, but they do to Medicaid. And another big point here is that if you take the amount of overpayments that MedPAC estimates, there's an estimate that over a decade that'd be around $1.2 trillion. That's more than they are trying to save by cutting Medicaid. So they literally could just swap the two and say, yeah, we're not actually going to cut your coverage, low-income people, but we're going to stop these giant profitable corporations from ripping off taxpayers. They could do that, but they choose not to because, money in politics speaks volumes.
Yep. No, that's pretty much on the mark. Well, we could probably go on forever on this one because it's obviously a huge issue, both in terms of, the budgetary issue, but obviously more important in terms of people's health and their lives. We'll see if we can make any headway in the right direction. It doesn't seem we're doing that right now, but maybe a little bit down the road. Well, thank you both for spending time with me and talking about this topic, and we'll probably, for better or worse, have occasion to talk about it again. So thanks for joining me.
Thank you.
If you like what you just saw, please help us out by liking us and subscribing. Thank you.